Good evening, ladies and gentlemen. First of all, thanks to the organizers for allowing a department to present this work here. And I'm also thankful to them not allotting a surgeon as a chairperson here, because that makes my life much simpler after I present this data to you. So just to tell you about AV fistulas, we all know that the fact that AV fistula is always the preferred vascular access because of innumerable reasons that we are all aware of. And the aim of this study, the reason why we did this study in 2012 was because there was a paper which was published in the Kidney International, which was about the Americans trying to say that whether the nephrologist should go in and do AV fistulas or not. So we tried to compare our primary AV fistula failure rates with those of the vascular surgeon. So this was basically a retrospective analysis that we carried out over a period of 1 year, followed up these patients for about 6 months. And we, as a protocol in our department, do all the radiocephalic AV fistulas, and we don't perform ultrasound Doppler vein imaging of all the patients unless we find that on the Tunicate test we are not able to find the cephalic vein. And most of these patients in whom we don't find the cephalic vein, we refer them to the vascular surgeon, and then he goes ahead and does the brachiocephalic or the brachiobasilic fistulas. So the data for this study was actually collected over telephonic conversation, and the physical examination was then performed on these patients. We defined the primary failure as the regular definition as an AV fistula which did not mature and could not be used for hemodialysis ever. So this was the first arm, the first group, that is the R group, which is 301 patients were enrolled, and 270 patients, the data was collected only for 270. In the second group, there was 198 patients that we could isolate, and only 189 of these were available for analysis. When we tried to just run a few patient characteristics, we found that there was no major difference between the age and the comorbidities such as diabetes, coronary artery disease, and peripheral vascular disease in terms of statistical analysis. But we did find that in our group, that is the nephrologist group, there were more males as compared to the females. And also, there were more males as compared to the vascular surgery group. So from our perspective, what we found was that nearly 1/4 of our fistulas had primary failure, as compared to just 1/5 of the fistulas of the vascular surgeon. So that is very interesting for the vascular surgeon, because they might think that they're doing better fistulas and brachials because they're more trained than we are. Then we further went down and we tried to find out what the risk factors, the traditional risk factors as in the textbooks, we tried to just kind of find some data on that, and it was just a reiteration that diabetes appears to be the most common risk factor, followed by coronary artery disease. Unfortunately, we didn't have too many patients on peripheral vascular disease. But what was interesting was that if you look at this arm here, this is the nephrologist arm here, that is the blue and the red. And we did find that in our patients, we were not doing well when we had these kind of, when we had these comorbidities. In terms of complications also, we found that our complications of hematomas were slightly higher as compared to the vascular surgeon group, but statistically, it was not very significant. As compared to other complications, there was not much difference. So to bring it to an end, the statistical analysis actually showed that between the two modalities, that is radiocephalic and brachiocephalic, there was no difference in terms of presence of comorbidity of complication rates, and the Z test that was used also showed that the primary failure rates were equal in both the fistulas. So this is just a comparison of a few studies that we saw. And the studies over here that we compared, are is unpublished data, and then you have 2 studies from the Indian part of the subcontinent, and you find the primary failure rate is very low in this study, though we have a primary failure rate of about 24%. So to conclude, diabetes and coronary artery disease are obviously the significant risk factors. It's a reiteration. There were higher number of hematomas that we made with our fistulas, but fortunately enough, they were not statistically significant. And also that we have almost comparable success rates of maturation when we compare it statistically. There were some limitations in our study. We did not do the routine preoperative ultrasound vein mapping, and we did not check the long-term patency rates of our fistulas. Also, the study period was a short period of just 1 year, and peripheral vascular disease patients were very few. And we did not compare similar form of AV accesses, because as a protocol we do only radiocephalics and we leave the brachial fistulas to our vascular surgeons. And thank you very much.
Very good presentation, Vinant. Just one comment, because you technically given the less normal veins to the vascular group, they may not be directly comparable, but I wonder, have you considered doing a propensity score match analysis for the groups that were kind of identical to see whether there's some difference? It may be interesting to see what comes out of it.
Yes, actually, we are just trying to analyze some more data on this study. This was a very old study. We did this somewhere in about 2012, 2013. So we're still enrolling more patients for that kind of an analysis. We've been told that we need a study group of more than 500 patients. So unfortunately, we were not able to do that on this particular group.
Sorry, with the permission of the chair. That's fantastic. Congratulations. I think you will soon, obviously, you will soon get the surgeons out of business. That's for sure. But regardless, I mean, I must say there are three things which you brought out which are extremely important. Number one is very important, which is the fact that most of these patients, in fact, all these patients must have, if you are looking at long-term access. See, this is not about a turf battle that a nephrologist can do something better than a surgeon. What I'm saying is that for long-term access, if you're looking at primary patency rates, I think it's extremely important to be selective about these things. You know, the lady before you, she spoke to you about the size of the artery and the size of the vein. I think those are extremely important ultrasonic criteria which must be followed before we take a patient up for fistula. Otherwise, think of something else. You know that you're going to be running into this thing. That's number one. And number two is, as he very rightly pointed out, I think it's an unfair comparison that you've done. That you've chosen all the juicy cases for yourself and you got the surgeons to do the difficult ones. Not that they shouldn't be doing them, and not that you shouldn't. And the third most important thing is that it's all about training. If you can train yourself, I am firmly of the opinion that a well-trained nephrologist can do a far better job than an untrained surgeon. Thank you.
Yes, Rajiv, you are right. Actually, when we were creating, and you never came to the OTs. But definitely our younger people, they are giving surgeons about brachial AV fistula.
So there's no refuting the fact that we depend on the surgeons totally, but statistics is on our side for this study, maybe, I don't know.
Yeah, we'll have to move on to the next paper, Mr. Chairman. Thank you very much.